Thanks. So, as Enid says, my time management is really crappy. So I'm going to try, and I'm not an experienced speaker. I had a lot of nerves about it. And then, as I said to her the other day, I said, I realized two things. One was that I'm really passionate about the subject, so I'm hoping that that is going to be just sort of what carries me through. I spend all day, every day, talking to people about this stuff, so hopefully that'll serve me in this. And then the other thing is that not only am I figuratively among friends, because you guys are all of, hi, Lindsay, come in. Because you guys are all sort of the same, probably, you love animals, and that kind of makes me think that you're all people that I would like to have as friends. So, and some of my actual friends are here. So anyway, I am talking about hospice, and I hope that I can give you something that you don't already know. I know that a lot of you guys are very, very into the industry, and some maybe not so much. Can I have an idea of how many vets are here? 2 vets, okay. And any technicians? 1 technician, okay. And everyone else doing shelter work, rescue, foster, that kind of thing? Anything else that is way different than that? Okay. So that helps a little. This is not a particularly in-depth, like I don't have drug doses and that kind of thing up there, but we can talk later if you want about that. So anyway, so this is me. I've been practicing for 15 years. I'm Canadian. You'll probably be able to hear that at some point. I've been in the States now since I graduated in '99, and I worked at Dove for 3 years, which was really, really interesting and really, really hard. And I missed the interactions with the clients that were extended, they come in. And so those relationships were really important. And so I left, sort of burnt out, looking for a change of pace, fell into house calls, literally. It was kind of the only job that was available at the time. That was before the economy tanked, and loved it. So I had a baby, then I started at-home veterinary services. Now there's 3 of us, Heather Dillon and Catherine Kirstein and myself, and we have a couple of technicians, 1 licensed. I am looking for another licensed technician, so if anybody knows anybody, I'm just about to put that advertising out there. The hospice side in particular is growing, and we're going to get a laser and all that kind of stuff. So anyway, I have a full-time office coordinator who answers the phones, Linda. She's amazing, and my husband is the practice manager. And there is no clinic. We have an office and warehouse, and we operate out of there. That's where the vehicles are and stuff. So this is the kind of stuff I'm going to talk about. I mean, hospice, you think terminal diagnosis, but obviously it's old age, very, very old age animals as well. And I will talk about that. What is animal hospice anyway, which is a new-ish concept, the philosophy, team, and goals. And then the second part, which is more the kind of the meat, the quality of life issues. I'm not going to go too deep into the quality of life scales because Lori Gibson did that in January a little more than me, but I will sort of touch on that. And I think the important point here is that it's not just about the animal, it's also about the caregiver. And that's something that we in our work, we have to sort of think about too. Ways to improve comfort for cats and dogs near the end of life, and getting closer to the end. How do we know? And what do we do about that? What do we put together as a plan? What do we prepare for that? And then I've got just a couple of little case studies and some show and tell that I have. So now, in years past, when an animal was given a terminal diagnosis, a lot of times what was presented to them was your dog, your cat is going to pass on soon, do you want the euthanasia today or tomorrow? And a lot of those people and a lot of those owners were not really ready. I mean, a lot of those people and a lot of the animal people were not ready either for that at that time. So now it's a little different, a little little better, I would say, in that there are more options. The aggressive, and I don't mean that in any kind of derogatory way, but that's how people present it to me. I don't want anything aggressive. That's what they say. And really, those things are often things that are surgical or, require hospitalization for an extended period of time. And most people really that I see don't want that, or else they wouldn't be calling me, because I do everything in the home. So that, and then there's aggressive palliative treatment, which is really like the palliative radiation that people do to shrink tumors to make the animals more comfortable. That's still kind of I wouldn't say invasive, but it's expensive and it's incredibly effective, but it's a big deal for a lot of these animals. It's stressful, it's anesthetic, it's time every day going to the vet or once a week or whatever. The euthanasia I mentioned, some people try to plan for a natural death. I'll talk a little bit more about that later. And of course what we do, which is palliative or hospice care. There's an International Association of Animal Hospice and Palliative Care that has been recently set up, and Enid and Heather Dillon and I went last year, and Heather and I went the year before, and it was really interesting. They have been working on trying to come to some consensus, and this is not just vets, it's technicians, it's social workers, it's all kinds of, Reiki practitioners, and everybody who has anything or any interest in helping animals at the end of their life feel better for the length of time that they have left. And they've come up with this definition, which I think it just came out a couple of months ago. So the key points are that we're talking about the animals' social, physical, emotional needs. We're talking about and they describe it as a philosophy rather than, it's nothing that's written in stone, provided from the time of terminal diagnosis through the death of the animal, inclusive of death by euthanasia or by hospice-assisted natural death. And the other big component, and I'll talk a little bit about that in a minute, of it is the mental health of the caregiver is a much bigger part, I think, and it's acknowledged as a bigger and more important thing than maybe it used to be. And the multidisciplinary healthcare team, that is really what defines it now compared to how it used to be. I think it used to be, your vet gives you the diagnosis, is there for you for the euthanasia, and then you're kind of on your own. And I think we all know that that's not quite how it is anymore, and there's lots of resources. So I'm going to make a little distinction from palliative care. The two terms are used interchangeably, I would say, by many, many people. I think that they're a little different. The way I use them, and I think a lot of people would use them, would be you can have palliation, you can have long-term palliative care. When your cat is diagnosed with kidney failure and you start giving fluids and you're told, okay, you could have from 1 year to 3 years here, that's not really hospice. That's probably more palliative care. You're not trying to cure the disease. You're trying to make them more comfortable. You're not anticipating that they're going to, pass away anytime suddenly or soon. And really, if you're going to go you're not going for a cure, because that would be kidney transplant, right? So that's a little different. Hospice, and there are definite differences as far as how long, but probably somewhere between 2 months and 4 months. Most people would say, all right, if you're expected to live 4 months, then we'll put you in hospice. Now, we're wrong about that a lot of times and how long they will live, but when you get your best guess. And the other type of hospice I wanted to mention, which is one that I love, and I have many, many clients who do this, and it's just a little bit different in that when they say they do hospice, and those are people who, out of the goodness of their hearts, they go out and they look for the animals that are the oldest, the most decrepit in the shelters, and they say, look, I'm going to take you home and I am going to give you love, I'm going to give you comfort, I'm going to take away your pain, and you're going to be with me for the rest of your life, and somebody's going to love you when you die. And that is so, it's amazing. And that is something that it's a little bit different in that those people kind of go into it and then they do it over and over and over again because it's so rewarding to them. But it's a little bit different than kind of when you've had your dog for 16 years and then you're not experienced in this, and then you go ahead and have to deal with this with your pet of that long. So it's kind of a bridge between the terminal diagnosis. It's the I'm not ready to lose him now kind of thing. Optimizing the quality of life, supporting, assisting, comforting, educating the caregiver. That's the kind of stuff that Enid does. I mean, we do it too, but we're not professional therapists. And I sort of threw down some keywords or concepts. I think the ones I hear over and over are, peace and compassion and quality over quantity. I hear that all the time. And I think part of what the hospice philosophy embodies is the acknowledgement that, hey, this is important and it is hard, really hard. So that's that. Now, these are some of the people that are potentially involved in the whole thing. As you can see, there are many from the crematory, massage therapists, alternative therapy providers. I mean, it's not uncommon for my patients to have myself and an oncologist and another vet who comes to their house to do acupuncture and somebody come to do massage and then then I'm on the phone talking to the compounding pharmacist, and so there are a ton of people, and of course the primary caregivers are there. And so it's a plan. That's something it tries to make it a little more, all right, well, we talk and we say, hey, what do you want from this? Well, I just want to make sure there's no pain. And some people are like, I want to get them through to when, I go on vacation or whatever it is, but it's sort of talking about the plan, keeping them comfortable for as long as possible, giving the owners what they need to know and preparing them, and the progression, because it is a progression, obviously, towards the inevitable death, peaceful passing, and skilled and compassionate grief support before and after death, because before, for a lot of people, is as hard as, or harder than after. So the natural death, I'll tell you a story. When I went to that first conference 2 years ago now with the International Association of Hospice and Palliative Care, they couldn't have picked a longer name. But I was terrified. I walked in there and my nerves were just, I was sick. So I felt like I'm going to walk in there and it's going to be a bunch of people who their primary goal is to make sure that these animals have a natural death. And it was killing me until I sat down in the first lecture and I heard, and I thought, oh, no, these people are, what they want is to have no suffering. What they want is a comfortable passing. And yeah, there are people who lean a little more one way than the other, but in general, it really was enlightening to see that our society has evolved to the point where it has come back. It's not about your own agenda. It's about, the animal and supporting the people go through that and stuff. So that's why I say it's a little controversial, because years ago I think it was more polarized and much more, you either did euthanasia or you did natural death, and it didn't quite match up. Our philosophy is really, when I am called about a hospice patient and we talk to the people, we make it really clear that, and through talking to them, we sort of come to an agreement or an assessment or a plan that it's going to change over time. It may change over time, what our plan is, but that we are going to have the comfort of the animal as the most important thing, and the best laid plans are often not able. It's just like when I made my birth plan, no meds, natural birth, epidural and C-section is what I ended up with. So it's not something that we always do, but I sort of say to them, look, if it gets to the point where I feel like I can't be a part of this because it's too, I feel like I can't sleep at night because I'm thinking they're not. If I can't alleviate that suffering, we either have to let them go, or you need to find someone else to help you with this, because it's, you got to be able to sleep at night. And interestingly, in the years that I've been doing this, I have never had anybody who has wanted to go further than I ever felt was comfortable. It's been really interesting. It usually, and you work as such a team and stuff, and you see, and sometimes people need a little more time, they need a little more help, but they're all, anybody who cares enough to call somebody to come to their house to help them through this, they have the same goals. And I've never had anyone to say, no, I must have a natural death. I have had people say, I hope they die in their sleep. We all have heard that, and we all sometimes, in the back of our mind, kind of wish that was true. But so that's that. And then thinking about quality of life, have you all seen those quality of life scales? Essentially, when you're trying to figure out what to do about measuring quality of life, it gets really dicey. And so the scales that are out there, I think, are not necessarily, they don't really apply to every situation. And it would be nice if we had, and I know people are working on this, that they weighted some aspects more heavily than others, like pain or difficulty breathing. In my book, you can't have pain, you can't have difficulty breathing, right? But, okay, so some of the other things are a little bit more negotiable. They should be individualized for the animal, for the species, for that actual individual animal too, because what is really important to one animal may mean nothing to another animal. And they should be able to be used easily, because you're doing it every day. You don't want to have to sit there with a calculator, okay, we got number 3 plus 6. And then consider the physical and emotional state of the animal. And I think we must consider the quality of life of the owner too. I think they're a team. So these are the things, some of the things that affect the quality of life of the caregiver. And for you guys, if you're out there and you're dealing with either as a caregiver yourself or dealing with your clients and so on that are caregivers, it used to be when I worked in a clinic, I had a little bit less empathy. I would wonder why this person standing in front of me couldn't manage to do, give the fluids, or they couldn't manage to do the medication or whatever. And I'd think, it's the dog just pooped on the floor. It's not that big a deal. But once I started going into their house and I started to see what they are dealing with in the rest of their lives, and okay, there's grandma in a hospital bed in the middle of the living room. It's like, yeah, you can't, they can't do it. So time, how much time do they have? Money, physical ability. Some of these dogs that are big are, that is a limiting factor on how long they can go on. Other obligations, previous experience, and that's another thing. And you all know that once you've gone through this once, the next time you have learned something from it, and you think, next time I'm not doing it that way. I'll try a little harder, or we'll do a little less. And I think that's important to recognize, that these people have all had a history of their own losses with people or their own losses with animals. Some people just can't handle the roller coaster, and that's okay. If you can't handle it, it's fine. The quality of life of the pet as time goes on and how long it continues, because when it's long and drawn out, sometimes they just can't do it. And then support systems that are available. This is the main scale that I was talking about, the 5 H's, and I always have to count them, and 2M scale. And so you look at this and you see all these things: hunger, hurt, hydration, hygiene, and more good days than bad. 0 to 10 on each criterion. Score of over 35 points represents acceptable quality of life to continue with pet hospice. Well, and I would put up there that if you had 0 in hurt, but you get 10s in everything else, you're not hungry, you're not hydrated, you're not, or you are hydrated and you are clean and whatever, although it'd be hard to be hurt and happy at the same time, you could have a score of over 35, but not have a good quality of life, I think. And that's one of the things, is that trying to weight in the relative importance of some of these things. And there's a couple other ones too. I'm going to try to work on one myself, but it's really complicated. So now I'm into sort of the ways to improve the comfort of the cat. So so this is sort of the more meat of what can we do part of the talk. Cats, as I think we all know, if you work with cats, are very different. They're not dogs, they're not people. And knowing what's normal for them and what is normal for your cat is key. And listen to them, be observant. I've written respect the cat twice because it's important. Their personality and their temperament dictates what you can do for them. And what you would do for one cat, you can't do for every cat. And they're calling the shots like usual. Ask for other options, think outside the box. It's a lot of times people are like, I can't medicate him because I can't get the pill in. Well, guess what? We can teach you how to do injections. We can teach you how to do injections if that helps. And then trust your instinct. It really is, you know them best. So pain control, again, I said I'm not going to get into drug doses. There are many different kinds of medications, but don't overlook acupuncture, laser, massage for some cats, depending on the cat, again, heat therapy. So these are what I consider to be probably the two that are that really have a lot of weight for cats. The other is respiration. I have yet to have anybody, I was really close, anybody who wanted to do oxygen therapy in the house. We could work it out, we could do it, but then you sort of have to think, and ultimately this is what happens, is we talk about it and say, to what end? What are we going for here? If we have to have an oxygen tank, and if it's something that's terminal, that's a little different than when you have a kitten with really bad upper respiratory that needs oxygen, right, for a limited period of time, and you know that, okay, we might get past them. In the home, in this scenario. Now, thoracocentesis, which is removing the fluid from the chest, for anybody who isn't aware of that term, it is... so there's fluid outside the lung. That can be done in the home. I've done that in the home before, and that can allow them to breathe better. I think the thing is looking at the whole cat and taking into account all of the other things that are also affecting the quality of life. And sometimes when you take away pain or take away a sinus infection or whatever, then you have improvement in something else. Little tricks. With cats, anybody who's been around cats knows that you need an arsenal of little tricks. And what little trick will work for one will never work for another cat. That's the pill pockets and the cream cheese and that kind of thing. I've written some of these on the bottom. Medication administration, a whole list of things that I've tried and used and that I've had success with, depending on the animal. Dental pain, keep the nose clear. That's something, sometimes I'll go see these animals. They can't breathe. It's like there's a serious crust across there. And consider dental pain and treat infection. Now, most animals in hospice, they've got 2 months left to live. You're not going to suggest that they go have a dental. It's under anesthesia. It's just not usual. But you do have to take into account the pain of dental disease. And maybe sometimes you can treat it with antibiotics if it's an infection or whatnot. Appetite stimulation and nausea control, there's good medications for those. Sometimes via injection too, a subcutaneous injection that the owners give. It can be really, really nice. And constipation, that's a big thing because a lot of people aren't even aware. I've got the two extremes, the people who are really aware of their animal's bowel movements, right? And they're always calling me, he hasn't had a bowel movement in 12 hours. And the other ones who are like, I don't know if he went to the litter pan. And so that's something, and if you see vomiting or not eating, definitely check for for constipation, sorry. So I just wrote some stuff on the bottom. You can all read those, I'm sure. Hydration, I actually kind of got in a little scuffle with a local specialist about the hydration issue for cats. We're talking about hospice, and he said, well, you wouldn't give them sub-Q fluids because it's hospice. And yeah, he said that, and I'm not going to tell you who, but he said, no, that's prolonging their life. It's not hospice. And I said, I'm sorry, I'm going to have to disagree with you. It's comfort. And if it keeps you from being constipated, if it keeps you from being nauseous, if it makes you feel better, gives you more energy, have all the fluids you want. And it just baffled me. But that's the thing. There are many different philosophies about what is hospice and what isn't. And he and I will probably never agree on a lot of stuff. So control of concurrent infection, concurrent diseases, that's another thing. And in this I wrote, pick and choose your medical testing. I mean, it's really easy to get caught in the circle of you've got a dying cat and we should check blood work every day, or we should check blood work every week or every month, check a urinalysis. And I would say to you, one thing, is it going to use all the resources of the client so they have nothing left for pain control or for whatever, food, medication? Is it going to be too stressful for the animal? That's key, because it cannot be worse than the disease. Whatever you're doing can't be worse than what they're already experiencing. Can it be done in the home? I have VDIC comes to our clients' houses and does abdominal ultrasounds and stuff, and cardiac echoes and stuff for us, which is nice for the animals. And the big thing is how the results will change the outcome or improve comfort. Because if it's not going to change anything that you're doing, then it's really academic, right? And that I think is important. Learning that it's not about what the numbers say, it's what about the animal in front of you is saying, and how they're looking and feeling. Mobility. I think one of the things that I've noticed in transitioning from regular practice to the house situation is when I was in regular practice, I never treated any cats for arthritis. It was really rare because you don't see them move. You don't see them walk. They come in their little meatloafs, or they're hiding or scratching at you, and you're like, okay, slam the lid back on. I don't, all right. So it is something that when you're in the house and you see them and you're like, holy crap, you really need some help. And then things like litter pans. I mean, how many times I've gone in and seen, they're missing the litter pan. The litter pan's this high. The cat's 20 years old. It gets up to the side, and it's like, all right, I'll just go right here because I can't get over that. I can't get over that thing. So I've found things like those cookie sheet or jelly roll pans. They have a lip this high. Just sort of thinking outside the box again for cats is often right, right, outside the box. And things like the location of the food bowls. Oh, he seems to be losing weight. Well, yeah, because your food is way up here and he can't jump up there anymore. And that's a common thing you see too. And then you can get these little steps, to the bed and the couch. And I'm always amazed how creative owners can be sometimes with that. And comfort for cats. Okay, modified litter pans, litter pan placement. Make sure you don't just have them upstairs. The cat doesn't like to climb the stairs anymore. Make it easy. Watching those bowel movements, sanitary trimming, sometimes that can make a big improvement. You've all probably seen those little discs, I think I called it Snug Safe. I think they're called Snug Safe, that you heat up in the microwave. I mean, a heated bed for cats is nirvana a lot of times, and it's if you're uncomfortable with the electrical thing, that works. Catios. I know some people with catios. And sunny windows, leash walks, that a lot of times they'll really like that. And other animals, they develop their relationships with other animals. I listed just some other things, just taking the time to be with them. For a lot of people, just slow down from your busy life, let them be with their friends. And the key thing, I think, we all here would be if they start hiding or isolating, that means something to a cat. It means something is not right. Okay, so dogs, a lot of this is sort of repetitive, so I'll sort of skim through it. There are a lot of old arthritic dogs, for example, very geriatric, who have her on 5 different medications for pain, and that's what they need. And they function quite well like that, but sometimes you just need to come at the pain from many different directions. Again, massage, laser. Seek out more opinions and expertise. This is something that I've learned, that even though you may not ever be planning on going to see a surgeon because you're not going to do surgery on this animal, they have such a good knowledge of the musculoskeletal system that sometimes having a consult with one of them just to say, exactly what is causing this pain gives you some more ideas for, sometimes you're surprised it's actually not arthritis, it's a bone tumor. So things, can change from that. Same thing I said about oxygen therapy. But respiration, and it's important to quality of life, not just because they're physically having a hard time breathing, but also because it affects their sleep. And that, in fact, just yesterday, I helped a little dog who was in severe cardiac failure go because he couldn't sleep. He was, between coughing and his owner said, when I look at him, I look in his eyes and he is exhausted. Yep, it's important. So appetite stimulants, anti-nausea, that all works. And then, there is a natural decrease in appetite towards death, and that's when you kind of get into the balancing of, do we really have to, in the last days of their life, do we really have to try to get them to eat or not? And, they don't feel good when they're eating, but I know from my own experience with my mom, there is a time when they don't feel good when they are eating, and you have to sort of make that judgment call. Homemade food equals yum. The number of times that I've gone in and the people say, he's not eating, and I look and there's a bowl of kibble, and it's a 14-year-old dog, and that kibble's been down there for 3 weeks, and I say, have you tried canned food? Have you tried scrambling an egg? Oh, no, I didn't know I was allowed to do that, because isn't the kibble good for his teeth? Like, no, it's okay. So, make the homemade food. I actually brought a little thing. Now, honestly, this made one of my clients' dogs sick, but balance it. It's a supplement that you add to homemade food. But, in the last couple of weeks of an animal's life, do we really need to make sure that all the minerals are exactly balanced? No, it's about energy. It's about filling their tummy and feeling good and feeling like you can do something for them by making them a quesadilla or whatever. Fluids, same thing. I had a client who gave 1 full liter of fluids to her 80-pound dog every day for about 4 months. She had an IV pole. She had a cuff to pump it in there, crank it in. She had it down to a science. And he felt great with it. Without it, he felt like crap. And that's how he lived. And she bought them by the case, and it's good. Common medications, diuretics and prednisone and stuff. A lot of times they are very, very thirsty. So this is Lisa, and she's a client of mine. This is Mo, who is no longer with us. She's 16 in this picture, and she's a chocolate lab. And what she is wearing is one of these vests, and you've probably all seen them. This is my favorite thing. I call it the vest of greatness. It's a rough wear vest, and this one is well worn. We have about half a dozen of them at our practice that we loan out. It's like a library. And it's nice because the handle is, you can see it's in the middle of her back, and they used to call it her suitcase. And it just gave her stability. I mean, she could still walk, but going up and down stairs, it was really great. And so that was just a couple months before she died. They had her out in the water, and she loved it. And again, the importance to quality of life varies, right? For some dogs, if they can't swim or if they can't go fetch their ball, they're not enjoying themselves, and you take that into account. Fecal and urinary incontinence, obviously a big issue, sometimes more for the owner, but sometimes for the dog. We have a lot that we can do for urinary incontinence. We don't have all that much that we can do for fecal incontinence, but luckily it's a lot easier most of the time for people to deal, as long as it's not diarrhea, to deal with that. And a lot of people are, they're okay with that as long as it's not diarrhea. The urine scald, sanitation issues, that's just something to keep in consideration. Cognitive dysfunction, you've probably all seen old dogs and old cats who are clearly not quite there, and that may be because there is something organic in their brain, or it may be because they are, really, truly having some senility. And there are supplements and there are medications that are variably effective. I think one of the things that really works the best a lot of times is, and it's not a medication, it's just sort of figuring out how to configure your life and where to put the furniture and whatever to not have a problem, and how you can adjust for some declining senses. I mean, the nose is usually the last thing to go, it seems like. Their vision, their hearing, okay, that's gone, but they can still feel you, they can still smell stuff. So use some of those things, and there are lots of games and stuff that they have online for that you can hide treats and stuff for mental stimulation. And sometimes if they can't get up and run, they still do want to look for things. What else? Spoon with them, just be. Yeah, because sometimes we forget, and we're so busy taking care of them, we forget to just spend the time with them. And how do you know what is the ultimate goal? And that's something that we set out kind of at the beginning, and people tell me, and that can evolve over time. And a lot of times it will be that their goal changes, or, push comes to shove, then they'll be, hesitant and they'll change it. I think most people want a peaceful ending, and a lot of times their primary concern is, I just don't want it to be a chaotic event in the middle of the night. And that is a valid concern. I mean, if you want to know who's going to be there, and you want it to not be, rushing to the emergency hospital in the middle of the night, then that sometimes will be what influences the time. Consensus among family members, that's also an issue. I don't know if you guys have ever had a situation where you're ready but your spouse is not, or vice versa. It is common. I was ready for my dog Finnegan to go months before my husband was, and it was kind of a tricky little thing there for a while. The signs of impending death, I'm not going to talk too much about those, but most people have a good feeling for when you're getting close. They say, oh, she's shutting down, she's not eating. Sometimes it's a mental thing, sometimes it's an appetite thing or a breathing thing. I think that's what affects and makes decision-making a dynamic process, because sometimes it's not what you plan, and you have to just go. I've written up here intensity and array of emotions, and that's not my area of expertise, but it is something that I see. I mean, it can be really, really powerful for people, and the range from the guilt to the self-blaming to the pain and everything, and a lot of times it's really powerful before the animal is gone. Then, one of the things I always say, and you probably all heard it, is a day or a week or a month too early is better than an hour too late. And that is something that if you've ever been like I have and experienced a time with my own little cat that was too late, you never want to do that again. So think of how you would want to look back on it and think, because it's going to hurt as much today as it will hurt in 3 weeks or 3 months. It hurts. One of the things is, if you can plan ahead when, who, where, how, I think that helps a lot of people to be able to know, all right, when it's time, we're going to do it in the garden, and my kids are going to write notes, and that kind of thing. Enid has some, you're going to talk about that, right? Ways to memorialize. And then sometimes it's not your decision. I mean, we can make the best laid plans, like I said. Support from the family, from the hospice team and others, important. This is Yoshi. He's so, so sweet. And he had kidney failure plus a heart murmur when I first met him and some weight loss. We sort of went on. The owner didn't want to do a lot of aggressive stuff. And then in May of 2013, there was some abdominal fluid in his belly. We can feel it. He was still eating. She was giving him fluids. And then once the fluid came, then it was kind of like, okay. And his heart was, it was changing. It was progressing. And we had 2 pounds of weight gain and some cardiac changes in June. I removed over 1 liter of fluid from his belly. He lay on the dining room table, completely unsedated, and the owner scratched his chin, and we just sucked it off, and it was amazing. And he felt really good for weeks after that, and then we did it again, and she's taken him out in the yard. She's given the anti-nausea medication. He's doing well. He's eating. But then she figures he's getting tired. Like, we did it again in August. On the 30th of August, she decided, and he wasn't sleeping with her. It was interesting, kind of, that was one of the big things. He's always slept with me. He didn't sleep with me. Things are not good. Wasn't eating, still drinking, and she euthanized him. That's the fluid. Look how much fluid that is. That was in a cat who was like 7.5 pounds. And that's a big jar. Like, that's not a little jar. That's a big, I should have put a pen beside it like people do. So yeah, that was the first one. And the next ones were kind of more like just the little jar size. And that was him on one of his last days sitting in the sun out on you can see his eye, a bad eye there too. But yeah, he was really sweet. And this is Petey. Petey was owned by Rebecca, and he was 15 and a half. He has a little brother, a twin littermate, I guess they're called. And he had a bunch of stuff going on. He had a tendency to grow lipomas of the largest variety, huge, and she would always have them taken off because he's only this high from the ground, and it was always a problem. So he developed heart failure. He was enrolled in Dr. Rausch's heart failure study on a new medication. So it was lucky because he got a lot of, diagnostics that she wouldn't have been able to afford otherwise. And as it went through, it was interesting because she was going through her own medical crisis. She had cancer, the owner, and she was all alone trying to do. And her biggest concern when she was diagnosed with cancer was, how was she going to care for her animals? That was far and away her biggest thing, and it was heartbreaking. So anyway, she was determined in December that she was going to have this lipoma removed, even though he'd been kicked out of the study because his heart failure had come back. But she was like, I can't leave anything that I haven't done for him. I can't. And she couldn't talk about hospice. It was too much for her. Then he went into kidney failure from all the diuretics and medications that he had were really taxing on his kidney, and so she euthanized him. And it was hard, but it was not as hard as it would have been, I think, if she had pushed it a little further. And that's Rebecca, and that's her litter mate. He had a great life, a really, really good life. She had a dog walker come every day and take him to the park, and yeah, and that, I think, is it.